Good evening, everyone. Thank you for attending our webinar tonight, a conversation with Dr. David Rubin and Dr. Susan Coffin from the Children's Hospital of Philadelphia PolicyLab. I am Maria Edelberg. I'm the Executive Director here at the Delaware County Intermediate Unit. We have a pretty packed evening tonight, and so just to set some context before we actually get into the program. We solicited feedback from all of our participants tonight, and we have over 1,000 people who have registered for this event. And then we categorized the information you would like into 5 categories: instructional models, face coverings, social distancing and other safety health precautions, student and staff health and safety, cleaning, disinfecting, sanitizing, and ventilation. We are also live streaming this event, and we are recording it. So in about a week after tonight, we will have it posted. So if you'd like to review it again or you want to share it with a colleague, you'll have the opportunity to do that. Our format tonight will be Dr. Rubin and Dr. Coffin will provide some opening comments and thoughts. And then we're going to move into the question and answer part of the program. Joining me tonight are Dr. Marc Bertrando, the superintendent at Garnet Valley School District, and Dr. Maureen Reusche, the superintendent of Haverford Township School District. And I want to say a thank you to them for helping to organize and plan this event. Then we will have closing remarks after the question and answer, and then we will end the program. So tonight, you're really here to hear from Dr. Rubin and Dr. Coffin, and let me just do a quick introduction before I turn it over. Dr. David Rubin is the Director of PolicyLab at Children's Hospital of Philadelphia and a professor of pediatrics at the Perelman School of Medicine at the University of Pennsylvania. Dr. Rubin is one of the lead investigators on PolicyLab COVID-19 forecasting model, which is also known as COVID Lab, Mapping COVID-19 in Your Community, which tracks the coronavirus transmission and test positivity rates across all of the U.S. counties and projects case counts for about 817 counties with active outbreaks. Dr. Rubin also serves as the Director of Population Health Innovation at Children's Hospital of Philadelphia, supervising a team that develops and implements integrated solutions using clinical care and technology to be more proactively identifying and providing needed services to at-risk patients across primary and specialty care areas. Also, Dr. Rubin has been an incredible partner for us here in Delaware County. He has been part of work groups that we've had to help guide us in all of our reopenings. And he has been such a valuable member and has given us his wisdom and all of the knowledge that he has learned to impart upon us. We also have joining us Dr. Susan Coffin, who is a faculty member at PolicyLab, a faculty member at Pediatric Infectious Disease Epidemiology and Antimicrobial Stewardship Research Group at the Center for Pediatric Clinical Effectiveness, and also a professor of the Division of Infectious Disease at Children's Hospital of Philadelphia. Dr. Coffin is also an associate hospital epidemiologist after she served as CHOP Hospital's epidemiologist and medical director of the Department of Infectious Prevention and Control for over 10 years. She is also the medical consultant in the Division of Disease Control at the Philadelphia Department of Public Health, where she is supporting the COVID response for the city of Philadelphia. So at this point, I am going to turn over to Dr. Rubin for some opening remarks, and then we'll go to Dr. Coffin.
Well, thanks for having me today. I know this is a really challenging time for everyone. People, it's been going on for a while, and people are getting tired, but they're also really worried. And as Dr. Coffin and myself and the folks at CHOP got interested in this work early on, our eye has been on trying to figure out, would there be a window to open schools safely, particularly our public schools. I've been doing a lot of work personally, as has Dr. Coffin, with both public and independent day and boarding schools as well too. And certainly they have advantages that our public schools don't have, with ample resources, often bigger campuses, lower enrollment. But our eyes have been principally focused on helping particularly our region's public schools open. When we think about what the recipe is for a safe school year, there are two components for us principally. Number one is declining case incidence to the point, which would reduce the likelihood that you have kids or staff who are coming to school who are actively infected. The lower the incidence, the fewer those people will be. And the second is if you can combine that with strong safety plans that the two that would work in tandem to make it such that when you went to work or when a family sent their children to school, the likelihood of spread or an outbreak at the school would be lower. Now, Dr. Coffin's going to talk about what that looks like in a school day. But suffice it to say, in August, we released some guidance around thresholds that talked about if you had a full plan to go speed ahead, you had to actually get to fairly low incidence levels to be that confident to just open things up and go back to what you were doing before. But we also gave higher thresholds, up to about 35 cases per 100,000 that per week, that would allow, if it were stable or declining incidence with test positivity that was coming down, would allow you to kind of think about incremental opening, like building confidence with your younger kids in whom we believe the susceptibility of infection would be lower, transmissibility would be lower, and we still believe that based on the lion's share of the data that Dr. Coffin will review with you. Now, we also assumed, we received a lot of criticism back in August because we were among those, particularly in our recommendations, who advised many of our school systems to hit pause right after Labor Day. We suspected that college reopenings, that the returning vacationers in the end of summer and Labor Day, coming on the heels of what was a pretty rough Memorial Day and July 4th impact, would lead to some resurgence in the area. And that having everyone land at school on Tuesday after Labor Day with increasing rates could have been the recipe for scuttling all those plans that people have been working on for so many months. And opening schools is easier than keeping them open. We know this is going to be hard work for everyone involved. Even since those recommendations, though, we've also been trained to look at new data that has been emerging. Schools are opening in many areas. We're watching the experience of these independent schools that have already opened, parochial schools that are opening. And so we're able to kind of take what we put out in August and always be willing to recalibrate and understand how do we put it all together that might lead to what our recommendation is now, that a window is opening to potentially safely open our public schools throughout the area. I'll say a couple of the information. There was a study that came out in one of the medical journals that looked at the experience of the children's hospitals and was able to give us a much clearer picture for a given level of what we call measured incidence in an area, what that translated to in terms of the number of kids who were coming in for procedures in the children's hospitals and the proportion of those kids, or what we call their testing positivity, what it would allow us to estimate in terms of the number of kids who might be coming into school day one. And what we found is there was an inflation, there's what's most likely an inflation factor of about 10. So, for Philadelphia right now itself, which is at about 35 cases per 100,000 on average, that for the city, that meant that if you multiply that by a factor of 10, you'd be talking about a prevalence level of 0.35%, or about 1/3% on day one, which means a ratio of 1 to 300. If you're at 50 per 100,000, where Delaware is still sort of working its way down, you'd be at 0.5% or 1 in 200. And that's important because that provides really important context that's now been supported by data in terms of testing in some of our schools in the region and elsewhere that seems to confirm. If you're a school that has 1,000 kids in it, and you're at that sort of 30 per 100,000 level, you might have 3 or 4 kids on day one, and maybe a staff member. And then the real question becomes, if we're doing a good job making sure everyone's asymptomatic when they enter the building, if people are wearing their masks, doing their distancing protocols, the likelihood that that's going to confer risk to you, to your students. And we have now gathering evidence that at these rates that we can feel comfortable, and I think it puts it into context. There were also a couple, I think, of smaller stories that are very easy to interpret, and this one was even earlier than our recommendations. I don't know if you all remember that Missouri hair salon back in the late spring, that during the reopening, there were two hair salonists who had active COVID infection, meaning they were symptomatic and they were wearing their masks. This was down in Missouri, and they saw 140 clients. And of those 140 clients who were within 3 feet, not 6 feet, but 3 feet of these individuals, they tested all of them, and not a single person became sick. I just today heard a story about an independent day school reopening, and I think this is really exciting news for all of you who are worried on your end, that on their first, the week before school, when the teachers came in to prepare and had their meetings, one of the teachers tested positive and potentially exposed the other teachers. Now, they were all distancing and they were all wearing masks. They tested all the teachers and have now followed up with them since. No one got infected. This is important context in which we're going to have this conversation tonight, and gives us confidence that if we work hard on our protocols, that we can establish a degree of safety as we incrementally start to reopening our schools. Now, the last thing I'll say before I hand it over to Dr. Coffin is, in recognizing a window which we now see, we do think the Labor Day effects are moving into the rearview mirror. It's not to say that we won't have zero risk. You'll never have zero risk. But we are seeing test positivity, not just decline in southeastern PA, but Maryland and Virginia and in other areas. And even some of the areas in the middle of the country to the west, as people have stopped vacationing, they're hunkering down a bit more. And with the weather still being temperate, we now have this window. And I can remember when Dr. Coffin and I went back to work back in March, we were terrified. You know, we were at the height of an epidemic, and we're still continuing to see kids with our coughs and our fevers. Our staff was terrified. You know, whether we were physicians with health conditions ourselves, or nurses, or front office staff, we were terrified. But then we put into very strong protocols, which Dr. Coffin was very involved in developing those protocols with masking. And we're not seeing spread among our staff. And Dr. Coffin will talk about that. And I'll tell you that over time, a couple weeks in those protocols, you start to build confidence. And I actually feel safer when I go to work now than when I go to a market, because of the variable behavior. And so this all comes down to how, as you start your new year, how well you can actually implement these protocols. And I'm going to turn it over to Dr. Coffin to talk about that.
Great. Thanks so much, Dave. I thought I'd touch on 3 different things to kind of cue us up for questions. The first is just to remind people what we do know about children and coronavirus, and Dave has already underlined a few important points. Then just review what we think are the dominant ways this virus is transmitted. And then finally to talk about what we know can and will work to prevent transmission. And I think we need to talk about all of those, because all of those are going to be part of the recipe for a successful school opening. So early in the spring, we did not see as health professionals that many children who had coronavirus. And we were puzzled by this. Whenever we've got a new virus or a new strain of let's say a flu virus, children have a lot of disease. They typically lead the way. And so we were very puzzled by why so few children were getting sick. As summer emerged, as children began to leave their protective cocoons of houses and interact more with each other, with larger family groups, with friends, we all of a sudden realized, yes, children can and do become infected. Children can and do transmit infection to each other and to adults, and children can and do get sick. The good news is, for all of those situations, the capacity to get infected, the capacity to transmit, and the capacity to get sick, they do it at a substantially lower level in frequency than adults. And so we don't fully understand why. It may have something to do with basic biology and how a virus replicates in a child versus an adult, but it does appear to be true. And so this is an important foundation, I think, for our conversation. The The other thing to talk a little bit is about how does this virus get transmitted? And I think we've all become very aware of routes of transmission, which is someone who's been in the world of infection control for over a decade. I never thought I would be able to have these kinds of conversations with my non-medical colleagues, but everybody seems to know what I mean when I talk about an aerosol or a droplet or contact transmission, which makes me happy. I'm not sure it makes the rest of the world happy, but this is a virus where we've got really good data, and the data is getting better over time, that is primarily transmitted through respiratory droplets. And that's a really important concept to keep in mind, because respiratory droplets, while small, are still large enough that they can be caught by a cloth mask. They can be pulled down to the ground by gravity, and they can be stopped by a physical barrier. And so that leads us into what are the best ways to prevent transmission. So I basically just laid it out for you. First, by wearing a mask, you will stop the exhalation of virus if you happen to be one of those people who has virus but is asymptomatic. Masks will stop virus coming into you. That has something to do with the best selection of masks, but we could talk more about that later. The next most important thing to do is distancing. And distancing in school settings can be really tough, particularly public schools. So creative planning, scheduling, and use of available space, somewhat non-traditionally, may be a really great strategy to continue to review and refine. Cleaning is important. This is a virus that will live on surfaces for several hours. Surfaces like stainless steel and things like desktops. Doesn't live forever. And we don't really know that contributes very much to transmission, but it may contribute a small amount. And then finally, I think, and perhaps first, I should have mentioned first, is the importance of screening. And that is making sure that you, as members of the administration, teaching staff, the rest of the staff of the school, are doing your very best to be on the lookout. Am I developing any new symptoms that make me wonder, is it okay for me to go to school? This is the year to say, if yes, if there's anything that's worrying you, sit the day out. And I know it's going to be a challenge for everybody. We are going to have more staff and student absenteeism, and we frankly think that's a good thing. We want people to err on the side of caution. And then I think similarly, as the school day goes on, we need to be looking out for each other and calling out like, ooh, you look like you're not feeling so well. Maybe you should get going home now, instead of pushing through to the end of the day. And similarly, keeping an eye out on the students and having a low threshold to have the student be evaluated by the nurse and consider going home early. So with that, I thought I'd stop and we can turn it back over to Maria and the rest of the team and answer questions and continue the conversation.
I'm going to turn it over to Dr. Bertrando to start with our first topic.
Thank you, Maria. Before I start, on behalf of the Delaware County Superintendents, I wanted to thank you, Maria, and the Delaware County Intermediate Unit for organizing and hosting this event. I know that every time I'm in the presence of these two experts, I feel like I'm smarter as a result of it. So we really appreciate your efforts in organizing this. I also want to thank Dr. Rubin and Dr. Coffin. I'm not sure folks who don't interact with you on a weekly basis realize just how busy you are, and you consistently take time out of your day and at all times of day to assist us. And your expertise has been invaluable since the beginning of this closure, and words can't express how appreciative we are of that. And then finally, I want to thank all of our educators tonight. Our teachers couldn't be working harder. Our support staff couldn't be working harder in this virtual environment. It's a heavy lift, and I know hybrid learning is going to be perhaps even a heavier lift. So the fact that you took time out of your long day to learn more, to help your students as we start to bring them back to school, just know that we're very appreciative of that. So with that said, we'll get to our first question. And Dr. Rubin, you kind of talked around this issue, but since the Chester County Health Department is the health authority for Delaware County, what is your impression, opinion of the guidelines that they have set forth in regards to opening schools?
Well, obviously, I think your health department it's an important consideration. I think we have to remind ourselves that the thresholds that we're talking about, they're not absolute thresholds. To me, I think people misconstrued that when our recommendations came out, that people were trying, we just had the CDC provide recommendations this week that also had their own set. These are goalposts, and you have to interpret that in the context of the size of your school, the strength of your protocols, your confidence in your protocols. And so to me, I think that, what we've learned since we put out our own thresholds is there are different factors that go into it. But the consistent theme across all these recommendations is that you want to see stabilization or declining incidence. The absolute number, whether it's 35, whether it's 50, whether it's 100, in terms of what the state of Pennsylvania did to provide some more flexibility, and to recognize that county rates are not always reflective of your own district. There are districts within Delaware County that may have a little bit lower rates, and districts that may suspect that their rates, and they can often get this information from your health department, your rates might be a little higher. That might lead you to be a little bit more cautious. But at the end of the day, I think what's affected us is understanding what concretely what the magnitude of this is. Whether you're at 35 or whether you're at 50, and you're talking about the difference between 3 or 5 students showing up on day one, as long as you know that it's not in a period of rapidly increasing. I'm not sure that changes my risk assessment for that school. If you have strong distancing, masking, hygiene protocols, and you're doing really good surveillance, your protocol should work. And so that's what's really changed my opinion in terms of really trying to interpret the body of the evidence, the socio-emotional needs of these children, the families who rely on schools to be able to have some level of workforce participation. How well some kids, particularly our younger kids, we're talking about our elementary school kids first, whether they're able to learn virtually, certainly our special education kids. And so, it's my way of recognizing you're always going to have variability, but you have to kind of think about all those things together to say, what's the absolute risk that me, myself, or my mom was an elementary school teacher for over 30 years. And I told the superintendents this in a very tightly crowded school, PS 51 in Manhattan. And so, that particular school would not have done well. I would have probably been a little bit more cautious, but that school has since been closed down by the city of New York, and it's moved.
And you talked a little bit in the beginning about how private schools and independent schools, parochial schools, have an easier time pulling some of these things off. In Delaware County, we have a lot of differences in socioeconomic levels. How does that factor in individual school districts' decision making?
I know it'd go both ways. I mean, I think you could say, look, those are the kids that have harder times with accessing digital services. In terms of the kids, but the masking and the distancing works the same for those families as it does for others. I don't think of that as something that changes from kid to kid. I think it really, concretely comes down to what's the absolute magnitude of what you think the number of kids are going to be showing up on day one. How well you're implementing your protocols. That's what really matters. We obviously see kids from all socioeconomic backgrounds at CHOP, and I don't think I don't feel mindful of when I see a kid from, let's say, West Philadelphia as when I see a kid from Lower Merion. It's the same routine.
Thank you. Do you need to feed your dog?
Yeah, he's paying attention. So,
Dr. Reusche?
Thanks, Dr. Bertrando, and thank again to Dr. Coffin and Rubin for joining us. Dr. Coffin, I'm going to direct this set of questions to you because it deals with face coverings, masking,
Sure.
and you spoke about that in your introductory remarks. We know that in some of our schools, there are programs that house children where it's not possible for those children to wear a mask.
Right.
Maybe there's a sensory issue or, a host of other things. So do you have strategies that you would recommend in that environment when students are incapable of wearing a mask? And do you recommend mask breaks? And if so, what do they look like?
Great, those are great questions, and let's take them one at a time. First, talking about a classroom that's serving children with special needs, children who aren't able to wear masks. I think that those children can and need to be taught in person. I think they can be taught in person safely, but it may need to look a little bit different. So in those situations, I think we can consider what are the additional protections first that we might offer the instructor. And so that might look like using a mask with the face shield. So there's a double barrier between an unmasked student and a teacher, essentially creating the same amount of barrier that there would be if the student was wearing a mask and the teacher was wearing a mask. Another idea which I think is really useful to think about is this a situation and perhaps a time when you want to deploy a few more aides to help with managing kids who perhaps have behavioral challenges in the classroom and might need a little more coaching to not jump up and perhaps unexpectedly move into another person's space. Another idea related to that would be to perhaps prioritize individuals who are a bit younger to be the teachers in that class, understanding that older age is part of the story which relates to risk of having more serious infections. And so those are three things that I think are doable and can be considered. I guess the last thing I'd throw out is really good cleaning protocols so that perhaps once or twice during the day, as well as at the beginning and end of the day, the environment around a student who's unmasked is cleaned.
And mask breaks?
Sure. I think mask breaks are essential. I think, I need them. I assume most of you find that you do as well. But as part of our role as educators, I think we need to teach and model how to do this safely. And so the times to take and offer a mask break are when, one, it's truly needed, not just like, I don't think I need my mask right now, but a break would be warranted. And then two, a time when the classroom is under good control. So I would suggest that a mask break would be an option when all students are sitting quietly in their seat. There is not a lot of conversation, perhaps they're doing individual work. The other parameters that we've suggested to put around mask breaks are that students have a mask break for no longer than, let's say, 5 to 10 minutes. A mask break does not need to be long to be effective, and it really should just be a moment of pause and then back to wearing a mask. Children should be reminded you stay in your seat with your masks off. You never get out of your seat without a mask on. And I think all of those things can help create some structure around what might otherwise feel like a less controlled moment in a classroom during a year where we're relying on masking.
And earlier,
I've actually gotten some feedback from some of the school. I attend a number of webinars. I just wanted to add to that. I think people are worried about the kids being in masks. The kids don't seem to be bothered about it as much as the adults have been. And so, as you do those mask breaks, again, remember one of the concepts you'll hear about is 6 feet, 15 minutes. So if you're just doing a 5-minute mask break and everyone's distanced, you're tolerating that risk, but I would question how often you need to do that. Obviously, you have to take off your mask to have lunch, and we can talk about lunchtime. But it's you know, I would not overestimate the ability of these kids to wear their masks during the day, you know.
I think that's a great point. We've seen amazing adaptation and adjustment of really young kids to this. And I think that we as people that spend hours with children need to set the bar high. This is something we're likely going to need to have be a common part of our society for months and months to come at the very least. And so the sooner we can embed in our youngest children, this is just part of the way the world works these days, the better.
And the last question related to masks and face coverings, if the 6 feet of social distancing is not possible, do you recommend that everyone in that environment wear, you know, some type of a, you know, face shield in addition to the mask?
No, I don't think that needs to be a universal. I would, you know, put out a small challenge. Think about all of the other things you can layer in addition, such as orienting kids so that they're not facing each other, having fairly good structure to the activities, and really get creative as much as you can with your space use.
Great.
I took that question as what to do. You know, I would remind you, for me, the distancing recommendation, one of the reasons we went to hybrid plans was to focus on achieving that 6 feet of distancing. Physical distancing is perhaps, you know, alongside that masking, that is 80% probably of the value of what you're doing throughout the school day. So don't underestimate that importance. Obviously, the younger kids may need to cohort. Like say in an elementary school class, you might have you might do some smaller cohorting where instead of mixing the whole class, you have 3 or 4 kids for certain activities and brief interactions where you might break 6 feet throughout the day. But you know, I would try to focus on maximizing that 6 feet and the masking as the principal components of what's gonna work this year.
Okay. I'm going to turn it back to Dr. Bertrando. He has some questions about social distancing.
Yeah, so Dr. Rubin, I guess just if you continue with that thought. So one of the questions we have, is it too risky to have students and staff return to school if social distancing of 6 feet can't be achieved the majority of the time? I guess this question is complicated by the contradictory guidance that we've received throughout the closure, where the World Health Organization and even locally, the Bucks County Department of Health asserted that perhaps 3 feet of social distancing was enough.
Well, you remember there's different factors. I mean, if we had no cases, we wouldn't be in masks, right? We wouldn't be doing distance. So if you're at 5 per 100,000, if you're 10, you know, so to me, if you're you know, I would never have endorsed, I don't think that we talked about the 3 foot recommendation. It goes contrary to the evidence on respiratory droplet spread. If you're trying to minimize the likelihood of infection, you're going to try to achieve 6 feet. Now, certainly moment to moment that may be broken. And there may be times during the day that is impossible. You're walking through a hallway, but you absolutely need to be wearing your mask, and those should be sort of minimized opportunities, if you will, in terms of the length of time that you are within 6 feet of an individual. I mean, life isn't perfect that way, but between the distancing and the masking and the way you sort of move people through the building, I mean, that's why the strength of these protocols is extremely important. So I do believe you can get kids back. I do. But I would not be recommending classrooms of 25, 30 kids at 3 feet distancing. I just don't think that's safe.
And so I'm going to take that just a step further with specific to instructional strategy. So many, if not all of our teachers use collaborative structures within their classrooms for students to engage with each other. There might be 3 to 7 students in a circle of desks facing each other. That would be a strategy that we would need to find alternatives for as we reopen schools. Would that be correct?
Correct. I think this is the creativity of 6 feet and masks and hygiene. And obviously keeping it, symptomatic kids or whatever cold they have, out of the school. But be creative, work with those. Those are the moments of transmission. Within 6 feet, more than 15 minutes, and certainly without a mask. You eliminate those moments of transmission, you're not going to have transmission.
So then that brings us to our next question, which has been a concern for our special education teachers, especially those teachers who have students that require physical interaction and require lots of instruction that comes very close, well within 6 feet, sometimes well within 3 feet. So what are some of the things that our special education teachers and our paraprofessionals can do to keep themselves safe when interacting with these students? And specifically, what type of PPE perhaps works the best in those situations?
I'm going to defer to Dr. Coffin to talk about PPE, but I will just say this, is that in those special needs classrooms, you also have families who've probably been going the extra distance to protect themselves. And I would assume that the baseline incidence in those kids is probably lower. They're not mixing as much in the general community at large. So you're already starting out with likely a lower risk. Now we understand the high touch environment there. And certainly we, our teachers should be wearing PPE. We suggested some options for using younger aides in those rooms. If you wanted to create even more safety in terms of having more hands and trying to minimize the amount of time you have to be high touch, but the risk in that room is not the same as being in a room of kids in a mainstream classroom, right? And so that already helps you, but it doesn't. But I think we have to think about the PPE requirements and other ways to minimize risk. So, Dr. Coffin, what would you add to that?
Yeah, no, I think that's correct. There are some things that we could layer on to what we were recommending for the mainstream classroom, like Dave said. We talked about kind of introducing a second barrier, which would provide the equivalent of a double mask interaction with a teacher masked and then a face shield as well. That also provides protection for the teacher's eyes, which we know are a portal of entry if a person is unmasked and has the virus. We talked a bit about the environment around an infected person becoming contaminated with virus, and glove use is a great thing to do, not so much because you're going to get infected if you touch virus, but rather we find that when people are wearing gloves, it's going to greatly cut down with the number of times they accidentally touch their face, which we all do several times a minute, our sociologists tell us. And then the last thing, depending on the extent to which a child may have uncontrolled or inconsistent control of their secretions, drooling, etc., using some sort of a cover gown or an overshirt that can be taken off when the individual, the teacher, or the aide leaves the classroom. The last thing I'll throw in there is we've seen some creative use of things like plexiglass barriers. Purchasing barriers that are, high-grade plexiglass would get very expensive for a district, but a few types of clear barriers that could be put between students or around an individual student's work area may be useful in this environment.
Yeah, I'll add one other thing is it's been an explosion of creativity around face masks, actually, and a lot of it has been led by teachers. And I've seen some pretty, so if you hunt around, and particularly for those in special ed classrooms, there's some really neat sort of combinations of face masks and shields that have come out. I saw one from Alaska. I think I had mentioned it on a previous call. And so, I think you can think about strategies to minimize your risk a little bit more within those classrooms, and that also goes for those teachers who are worried about wearing the mask, which they're going to be wearing all day. There are even some face masks now that are clear over the mouth. So if you have kids who respond to visual cues or a child with ADHD in your classroom, you can consider that. So I think there's a certain part that our recommendations get you to. And then what I've been really I found pleasantly surprised about and found really interesting is just the way teachers will take those recommendations and then go to the next level.
Yeah, Dr. Rubin, in Dr. Reusche's section, you briefly mentioned food services and how to, I guess, safely feed our students while they're in school. Can you talk a little bit more about that?
Yeah, so in terms of I think we're recommending to avoid the cafeterias if you can, but if I think we're going to try to achieve that 6-foot distancing. I think the best is if you could deliver food to have the kids bring the food to class, or deliver box lunches to the classroom. That's probably the best solution that I've seen. And recognize that the moments that kids are eating and staff are eating, actually, it's your lunchroom breaks and your break room. That's where we've seen the most transmission in a lot of these employer environments. It's when you talk to your friends. But like each of those situations, what we're trying to achieve is a classroom eating quietly and not a lot of talking during that period. And the way that a lot of schools are doing this is they're showing like a really good documentary or an audible book and while the kids are eating for about 15-20 minutes. They may trade off a group of the class with another group of the class if that works, but that's how I've seen most people implementing the meal-related plans.
Great. Dr. Reusche?
Yeah, and I'd just like
Cool.
to underline
Sure.
one or two other things. I think it is really important to think of eating, in group eating, as probably one of the most high-risk moments any of us are going to put ourselves into. And in a classroom, in a teacher break room, socially with your friends, or out at a restaurant. And so it's important to introduce the concept that the mask comes off when you're actively eating and drinking. It's not as though you sit down at your lunch table and lunch period and you have a 20-minute or 25-minute period of being unmasked. It's really just while you're eating and drinking.
All right, we have quite a few questions in the category of health and safety, and I've tried to put some of them together so that we can get most of the topics addressed. The first topic here is about staff having COVID testing prior to the returning of school. Is that something that you feel staff should do, and should they do that periodically throughout the year?
So I'll start with that. This has been a strategy which has really gained favor in some small, very wealthy private schools and colleges. And I think the most important thing to remember is what a test will tell you. And a test will tell you one thing only: whether or not you have detectable virus at the moment the swab was in your nose. It will tell you no more and no less than that. And so it tells you nothing about what your risk of being infected or passing infection to somebody else tomorrow or the next day. And so for that reason, I don't think consistent testing over and over again should be part of a school opening plan. There are lots of times and reasons to test, and it's always important, no matter what our role is in society, that we get tested when symptomatic, that we consider getting tested about 7 days after being exposed, or if we're being asked to participate in a structured surveillance. But random testing is not going to, I think, advance the safety of the school.
Okay, great, thank you. Do you have any concerns over the fact that schools are looking to possibly return to in-person learning with the onset of flu season?
I've got a lot of concerns. I have so many concerns, but I also know there's a lot that we can do. First and foremost, this is the most important season to get your flu vaccine and to get everybody you know and every one of your students vaccinated. Number one. Two is to remember that, like coronavirus, influenza is passed through respiratory droplets. And so the same protocols that we're using to stop coronavirus passage should be stopping, to some extent, influenza transmission in schools. And then three, as we move into respiratory viral season, this is going to be a time where we're all likely to need to get one or more tests because we become symptomatic. We develop a respiratory illness. And this is not the year to assume like, oh, this is my usual stuffy nose that I get every winter. This is the time to consult with your provider and discuss, do I need to be tested?
There may be times as well too. The Southern Hemisphere had lower rates of influenza this year because people were masking, and so you're going to see, you should see reductions if people are following the protocols. You should certainly if your community is following some level of the norms around masking and distancing, you should see some reductions in a lot of these other respiratory viruses. But should that change, and you can't run a class if everyone's got a cold, right? Because we're going to keep kids out of school this year, right? So at some point you may revert to distance learning for a couple of weeks to kind of get things to cool down again and try to resume. Like, as we start, we also recognize there may be times during the year where we may have to practically make the decision to revert to distance learning, and that's okay. But the goal is right now is to, through our masks and our distancing and our hygiene practices and our surveillance, that we're going to have a safe school. That and one of the things people, if in the worst case scenario, if there's a breakthrough and both people are wearing masks, and we talk about this all the time, the likely dose exposure that you're talking about is much lower, which puts you at much less risk for severe disease or severe infection. So I think that's going to be a rare circumstance as long as we're following the protocols. But all of that gives us confidence that there is a route to safely opening these schools, even though the risk is never zero.
We've also heard about the pros and cons to taking temperatures as students or prior to students and staff entering a building. What is your opinion on that? And is it accurate that a temperature is the initial symptom for COVID-19?
So these are great questions. The proposal to do temperature screening sounds good. Unfortunately, we've now learned that it is not effective. What we've learned is that there are very few people who, let's say, are coming into a hospital. Our next door neighbors at the Hospital University of Pennsylvania have done probably 100,000 of these screens every day on their staff. They don't detect people with fever. So people who have fever are going to stay at home, most likely, when they do their own personal health check. I think it's much more important to focus on the symptoms that a person is having. Are people coming in that do have a cough, that do have nasal congestion, that are feeling run down? Those are the areas where I think our screening can be more effective.
Okay, thank you. And we got quite a few questions about the difference between isolation and quarantine rooms. And what's the difference? Are both necessary? And do you know how it would be determined if a class or a building needs to transition to quarantine?
So first I'll just kind of mention what we think in the public health world about how to think about what is quarantine, what is isolation. Quarantine is what we do when we think somebody has been exposed, but they have not yet developed illness. And so that is for someone who's essentially asymptomatic. Isolation is what we do when someone is infected and we don't want them to pass infection, spread the infection. Functionally, it looks pretty similar. A person is staying home. Ideally, they're not interacting with other members of their household because we don't want in-house transmission. And the duration of time is similar but not identical. 14 days if you're quarantining, 10 days if you're in isolation. The questions about how public health will advise you when a child or a teacher becomes infected are going to be very individual. There's not a big playbook that says, when you have 2 cases within this many days of each other, we're going to suspend, the classroom. We're thinking a lot about this, but the cases need to be investigated and see whether or not they're linked or not linked. I think patience and partnering with the public health department in Chester is going to be really essential to have good guidance on these decisions.
And we know that the governor has placed restrictions on the number of individuals who can convene indoors, and yet has stated that that does not apply to a school setting. Can you comment on the safety of that? Like, we can have 900 students coming to a high school, but not, couldn't have them convening elsewhere.
Well, I think of 900 people going to a concert is standing around for 2 hours together, packed into a concert room. I mean, it's 6 feet, 15 minutes. And so you're spreading the kids out. It's about dedensifying. And if you can dedensify, whether it's 700 kids or whether it's 1,200 kids throughout a campus, that's, you know, that's no different than what we're trying to do in the colleges and everywhere else. It's different than being in a small venue with 900 people.
I think it's all about the room. You know, when we talk about gathering, we assume they're in a shared space, not in individual classrooms.
So it gets to, you know, how are you going to, you know, to me, this is about the planning you make in terms of moving kids through the hallways. You know, this gets down to the strength of your protocols again. You know, think about the moments of transmission. You know, 6 feet, 15 minutes, masks, no masks, you know, and if you focus on that and you achieve that successfully, you should have very minimal transmission that's linked in the school.
And the final question, is there accuracy to the idea that the majority of children who test positive are Indigenous, African American, Latino? And if so, do you think there should be additional precautions taken in school systems that educate a high percentage of those students?
Yeah, let me speak to that. I don't think that's, you know, to me, there is truth that we have disproportionately seen infections and morbidity among African American and Latino individuals, but it's not a genetic thing as far as I'm concerned. I think it's more of an indication of crowded living conditions, multi-generational households, a lot of families. It's more about socioeconomics, you know, in terms of socioeconomic status, in terms of a lot of those people who are employed in those households. There's much more likely to be in public serving positions, as opposed to office-based environments where it's much easier to spread out. To me, it comes down to that fundamental equation. It's not about your background. It's about, are you asymptomatic? You know, is the kid wearing his mask? You know, are you doing your 6 feet of distancing? I will point out that Philadelphia's at 35 per 100,000 per week this week, and Chester is closer to 50 to 60, right? And so it's not entirely playing out during this pandemic is not entirely playing out along racial lines or ethnic lines. So I just think you know, what you can control is the focus on your protocols, and I wouldn't necessarily treat populations differently. If there's increased incidence in your community, or if we're starting to see spread, it's going to lead to the same decision whether you're in West Philadelphia or whether you're in Lower Merion or Swarthmore, you know?
All right. Well, again, thank you both. I'm going to turn it over to Dr. Edelberg for the category of cleaning, disinfecting, and sanitizing and ventilation.
Thank you, Dr. Reusche. Really, we have kind of two major topics here. And the first is, what are your recommendations around materials? Because especially with the younger population, we're constantly sharing materials. How might it be best to clean and sanitize? Do you need to do it each time? And then should students be bringing their materials home every day, and there should be any protocols set up for them to wipe down their materials? So I'm not sure, Dr. Coffin or Dr. Rubin, who would like to.
I'll start with that. I'll start with that. So for shared materials, this is a great time where if you can create less across student sharing and give them a group of materials, perhaps it's a packet with, I'm not even sure what would be in it, but you know, a book, their crayons, their paper, stack of paper that they carry with them. That's the ideal. Then the only exposure they will have is to their own bacteria and viruses that they are carrying. So the student to student passage is avoided. Next best would be to create a strategy where there could be a wipe down of a material before it moves from one child to another. And then the third approach, if that's not possible, would be to really fall back on very small cohorts. Maybe 3 students would be sharing materials, and maybe they would always be the same 3 students that are sharing materials. And so if we were to be in a situation where one of those 3 became infected, we would say, aha, we need to be more concerned about the other 2 members in that little micro cohort. So those are some things that I would think about in terms of how to move through those decisions about sharing and not sharing materials.
Now, one of the strategies we hear often, and it's on most of the posters that we all have posted around our buildings, is hand washing. Are there real critical times that it becomes so important that we want to ensure that we have a schedule? And what would be those critical events and or transitions?
Yeah, and transitions, that's a great way to frame it, because it really is at transition that we want to be doing that. So an obvious time will be getting off the school bus or the transportation to school and entering into the school. And similarly, entering into a classroom or a new shared space. Exiting those spaces would also be great times to insist on hand hygiene. And then other times, I think you can think about either event-based or time-based. Some places have gone to having a hand hygiene moment every 1 to 2 hours, where there's a 5-minute pause and everybody cleans their hands, using usually alcohol-based hand rubs. If it was going to be event-based, I think that I would really focus on what are those moments where children and teachers and staff are touching their face and touching shared things. So those are the 2 things that you would like to interrupt or put clean hands in right after somebody's adjusted their mask or somebody's been passing things to another person.
Yeah, I think at a very simple level, every time the kids change classes, if they're changing classes, I would like to see Purell stations at every door, and they have to do their hand hygiene as they walk in the door,
Yeah.
Ventilation is a pretty hot topic. And so, can you talk a little bit about, should there be fans in classrooms? What happens when a room might not have a window? How critical is it for a fan? Is there ventilation systems? Should there be measurement? If so, what does that even look like? So ventilation is one of those big topics because you can't typically see it. Yeah. So any recommendations or thoughts around ventilation systems?
Sure. I think one of the first things to do is to consider, why do we even care about ventilation? And we care about ventilation because it's going to move things around in the air and dilute things in the air. However, if we're masked consistently, if we don't have people who have respiratory symptoms, and if we have a relatively de-densified space, all of those things are already providing that exact same benefit that ventilation would. If you do want to think about ventilation, though, some of the things to think about are using what you have. And by that, what I've been recommending is that have the building engineers go through and maximize the number of air exchanges that each classroom can be set to. What I've been hearing is that many classrooms exist with about 5 air exchanges per hour. A hospital has 6. That's basically no different. You're getting hospital grade air there. The other thing, which I think is pretty doable, it doesn't involve remaking an HVAC system, is making sure that there are clean filters in and making sure that the system has been recently serviced. Those are the main things that I think are easily and consistently achievable. And if those were achieved together with good protocols, I'd be very happy to send my child into any classroom in this region.
Yeah, we talk about this all the time. I think it's such a huge flash issue, and there's obviously, watching what happened in Philadelphia last year in terms of Science Leadership Academy. I think that it's such a huge flashpoint, but the reality is masking and distancing is 90%. If you can, if it's easy to open a window. That's great. It's easy to do something in the gym or outdoors, particularly in the fall, as a way to decant. Why not? Those are easy solutions, but let's not overestimate the value of this if you're able to de-densify the classrooms and wear your masks. I think about my own office where I see patients. They put us in these tiny little exam rooms, and they put us in these tiny little exam rooms, and I think it's because they don't want the kids to feel like they can escape when we're trying to give them shots. But they're not well ventilated, I can tell you that much. And we just minimize the amount of time we're in the room with them, and we're dealing with sick kids, and we haven't had transmission. So I think that kind of puts a sort of a practical reality on it. You do it if you can. But don't let that be the limitation or instill fear in you because it's your masking and your distancing that is conferring your advantage.
Yeah.
Thank you. Can I ask Dr. Rubin and Dr. Coffin to give us some words of wisdom as we are closing towards the end of this webinar?
Trust your protocols. Trust what you're doing. And if you can't trust what you're doing, that's the problem. It's not that, certainly we're not opening up like the South did at 200-300 cases per 100,000 per week. We're talking about 30, 50 to get elementary school kids back where there's even a lower, where their risk is even going to be lower. I didn't even mention a private school that pitched a 0 for 600 when they tested all their kids on the first day. The numbers are going to be small. And even if there's a moment during the day where there's an incident, that 1 in 300 still comes in your favor. That 1 in 200, you'd have to both have the incident and then have that be the one that was actively infected. And so, if you're playing the probability or the odds for my math teachers out there, that's going to be a lower risk event. You're probably more likely to get infected walking through your market in town. And so that's what I want to emphasize is that a couple weeks in these protocols, if the protocols aren't working, then I think people need to revisit them. But a couple weeks in these protocols builds confidence, and sometimes it's that first step over the threshold that is the scariest.
And then for me, the one thing that I do is make sure that you have a plan to help people commit to continuing to adhere to these protocols. Don't let people build bad habits right from the start. Don't tolerate people wearing a mask around their chin or underneath their nose. Don't tolerate people not using hand gel as they go into the school. I think it's going to be all of us as leaders in our individual work settings that will set the tone at the start and that will either make or break the ability to sustain this longer term.
Thank you. Dr. Rubin, Dr. Coffin, thank you for your continual guidance, your wisdom. Actually, you keep building our confidence and helping us put those right strategies in place so we can all be successful. To my colleagues, Dr. Reusche and Dr. Bertrando, thank you so much for helping moderate this session. We look forward to continuing our partnership with CHOP and both of you, and look forward to future sessions. Thank you, everybody who is in our audience participating. As I said before, we will be posting this, so you'll be able to see this event in about a week. So we'll get information out to all of you how you can revisit this webinar. Thank you and have a wonderful evening.
Thank you.